Upon Dr. Vishal to talk on diabetic macular edema clinical presentation, particularly role of steroids, lasers and surgery. Vishal is prolific surgeon, retina practitioner at Jaipur.
Thank you, Ajay sir, and thank you for making me a part of your wonderful course year after year. And I'll be speaking about the role of steroids. I'll be talking about the role of steroids and surgery in DME. Uh, Lasers will be covered by my subsequent speaker, Dr. Bhuvan. So, just a brief, we all know that the diabetic macular edema is a chronic and a multifactorial condition. It's one of the most common diagnoses we make in our retinal OPDs, and it causes a visual impairment that critically impacts a patient's quality of life. And traditionally and still, anti-VEGF agents are the gold standard for the first line treatment in the management of DME. But now we know that only around one third of DME patients show more than 3 lines of visual improvement with anti-VEGF, suggesting the role of basically inflammation in the pathogenesis of DME. And so many molecules are involved, and it has been proved, like addition molecules, ICAM, VCAM, integrins, IL-6, IL-8, and the role of Ang2 has been well established in the pathogenesis of DME. So, besides VEGF, there are various pro-inflammatory agents responsible for diabetic macular edema. And even if you see the data for anti-VEGFs among the eyes that showed limited initial visual acuity improvement with anti-VEGF monotherapy only one third of them showed a clinically significant long-term visual response, and at the end of the 2 years, the response was very less, and at the end of 3 years, it was less than at the end of 2 years. So the current perspectives on the role of inflammation in diabetic macular says that DME patients have elevated concentrations of these pro-inflammatory cytokines, IL-6, IL-8, MCP1, and of course VEGF. And for the concentration of the remaining cytokines, there was no difference between patients with DME and healthy subjects. So, what about dexamethasone? Is it effective in inhibiting inflammatory cytokines in DME? Well, the evidence says so. So, you can see the percentage of patients with a 3 line improvement from BCVA from baseline at the year 3 or final study visit. It shows a significant improvement in visual acuity. Even Dex implant 0.35 mg shows statistical superiority to sham patients. And eyes with anti-VEGF treatment in the first year, and they were switched later in the second year to steroids, also showed functional and anatomical improvements. And of course, those who switched early to dexamethasone in the first year, of course, had better visual gain. So eyes that switched early to dex implant had, of course, a better outcome because at 12 months, and could maintain it across the second year. And those who switched did not have that much improvement, but still they were better off than the previous anti-VEGF treatment, of course, because of irreversible photoreceptor loss. So why are we in our clinical practice hesitant to give steroids early in diabetic macular edema? Of course, the most common answer would be that we are, still averse with the, adverse effects like cataractogenesis, maybe IOP rise, and we all know that that can be easily managed by medical management, and cataractogenesis is not a very major problem, and the main concern is that we ourselves do not know that how many, what subset of patients have suboptimal treatment outcomes with anti-VEGF. We keep on injecting anti-VEGF, and many of these patients we do not follow up regularly to see the magnitude of suboptimal treatment load. So the guidelines say that it is the DEX implant is a preferred, you know, steroid therapy among all the available corticosteroids. It can be used as a first line in pseudophakic eyes. It can be used as a first line in patients with cardiovascular events, and those patients who are unwilling to attend monthly or regular anti-VEGF treatments. So the indications are steroid use is history of major CV events. Pseudophakic eyes is a first-line treatment, and in phakic eyes, of course, anti-VEGF is the first-line treatment, but can be given to patients not willing for regular checkups. And the expert recommendations using Delphi-based approach recommends that apart from the previous recommendations, you can consider, DEX implants in patients who are not responders or suboptimal responders after the loading phase of anti-VEGF. And among steroid treatment, dexamethasone intravitreal implants were considered to have the best ocular tolerability. So just to summarize, the naive eyes, treatment naive eyes, suitable patients are pseudophakic patients and not suitable for anti-VEGF agents or poor treatment adherence. So it gives good anatomical response, faster resolution, and does not cause systemic adverse effects. And in switch eye, non-responders, that after the loading dose of anti-VEGF, if there is only a less than 10% reduction of central subfield thickness or less than 5 liters of BCVA. And in inflammatory scenarios, on the OCT, if the diabetic macular edema shows the telltale signs of inflammation, that is the NSD, neuroepithelium detachment, or hyperreflective foci. So the key takeaways about the role of steroids in the management of DME is that, of course, we know that still the first line of treatment for DME is anti-VEGF agents, but many patients fail to show a visual response after a prolonged anti-VEGF treatment protocol. Inflammation is the main culprit in these non-responders, and intravitreal corticosteroids are useful in the management of DME as they block the production of VEGF and pro-inflammatory cytokines. So they show efficacy in the treatment of DME along with the favorable safety profile. So coming to the surgical aspect of the treatment of diabetic macular edema. So let's divide it into 3 parts. First is, of course, it's a recognized definite indication, that is a taut posterior hyaloid membrane, vitreomacular traction, and epiretinal membrane, which is causing actually a physical macular edema. A relative indication is a non-responder patient, that is a patient with recalcitrant macular edema after a prolonged therapy of anti-VEGF, maybe steroids, and still has persistent macular edema. And now studies have come up with treating ILM with vitrectomy and ILM peeling in treatment naive diabetic macular edema. I do not do that, and I think that comes in the category of overzealous treatment, but it remains to be seen what are the results. But all these indications yield excellent anatomical results with reduction in central subfield thickness. And the rationale is that vitrectomy, by doing a vitrectomy, there is improvement of vitreous oxygenation. There is a reduction of the cytokine levels and vitreous VEGF levels. And ILM peeling per se is beneficial for the resolution of DME and visual acuity improvement. So just a couple of videos to tell you how it is done. It's a straightforward surgery. This is a patient of taut posterior hyaloid membrane, and a PVD induction is there. You have to stain multiple times to reach the ILM because every layer has to be peeled separately. You can see this glial white tissue, and that is your taut posterior hyaloid membrane, and it comes easily with the forceps. You don't need you don't need even to stain it, and it's actually very it comes in one piece. And after that is removed, you again stain it with the brilliant blue dye so that the ILM now takes up a good stain. And this is the final peeling. So we have removed the vitreous, did a PVD induction, removed the taut posterior hyaloid membrane, and the final step is to peel the ILM. Of course, the traction was resolved and the patient had some improvement, but you can see that a subfoveal plaque over there, which did not, nothing could have been done for that. So this is the pre and the post OCTs. Another case of taut posterior hyaloid membrane. Here, the visualization was poor, so we injected trypan blue to stain the taut posterior hyaloid membrane. So it was, just forward it. So you catch hold of that with the end gripping forceps. Just the last video. And again, it, comes up as a sheet. In this case, it was bluish in hue because of the trypan blue staining. And the final step is the common ILM peeling after the third staining by BBG. And this is the peeling in a non-tractional edema for a recalcitrant macular edema without any TPHM or without any VMT. And you just do a simple ILM peeling in these cases, and the results are very good. Although many of these cases do not, the visual acuity improvement does not resonate with the anatomical reduction in central subfield thickness. So to conclude, vitrectomy for DME, the indications and extent keeps on evolving with time. No diabetic vitrectomy, mind you, especially for the youngsters, is a straightforward procedure, and you might end up in complications with poorer visual acuity than pre-op visual acuity. But of course, it remains an important tool in the management of select cases of DME. And the concept that thinner macula doesn't correlate with improved visual acuity should be made adequately clear during the pre-op counseling to the patient. Thank you so much. And